It is my pleasure to introduce our next speaker. When we were just chatting about, she might have a couple of years of experience at CMS, which is really valuable as you think through what can be. And in the case of the department that she's working for now, she's looking at all the possibilities for innovation. And we heard a number of examples this morning, but certainly it is our pleasure and my pleasure to introduce our next speaker, who is the Deputy Director at CMMI, Arrah Tabe-Bedward. Did I do it correct?
Yes, you did.
Okay,
you
great.
Did. Thank you so much.
With that, I'm going to turn it back to you.
Great. Thank you so much. Is this okay? Can you hear me well enough? Great. Thank you so much. And good morning to all of you. I'm really excited to be here, and I very much appreciate the invitation to join you today. I know that our director, Liz Fowler, was here earlier this year and shared a little bit about the Innovation Center. So I am excited to be able to join you today to share some additional background on the Innovation Center's role and purpose, to discuss the vision that we have laid out for the next 10 years, highlight some of the recent updates to existing models in our portfolio, and then introduce you to some of the newest models that were announced in the last several months. So that's my plan for today, and then I hope at the end we'll have a little bit of time for some additional questions. So let's just dive right in. If you're not familiar with the Innovation Center, it was created in 2010 as part of the Affordable Care Act, and we were charged with developing and testing new approaches to delivering and paying for care. And the goal was to improve the quality of care that was provided to Medicare and Medicaid beneficiaries while holding or even lowering programmatic costs. And this is mostly achieved through the development and implementation of innovative payment models. And when we think about the models that we test and trying to determine whether those tests are successful, the criteria for success are actually established in statute, and that's what you see in the light blue box. Those are the criteria that are set out in statute. If a model improves quality while maintaining costs, if it can maintain quality while reducing cost, or the gold standard, if it can improve quality and also reduce costs, then the Secretary of HHS has the ability to expand the model both in scope and duration, including making that test national and making it a permanent part of the work that the agency does. Some of you may already know what alternative payment models are, or APMs, but just want to spend a little bit of time on those and describing, in particular, the APMs that the Innovation Center has in its portfolio. They can be designed in a lot of different ways, but they are all consistent in the sense that they aim to improve care by rewarding providers for delivering high-quality, cost-efficient care. That is, they are paying providers for delivering on value and not volume. And the APMs that are in the Innovation Center's portfolio are actually pretty heterogeneous. They can be organized around specific health conditions. So we have a number of models that are focused on cancer care and oncology. Models can also be focused on episodes of care. For example, we have a model that focuses on lower joint replacement, and that is our comprehensive care for joint replacement model. We also have a number of models that focus on specific types of providers. So pretty much since the beginning of the Innovation Center, we've had at least one model that is focused on primary care. Similarly, we currently have models that are focused in the Medicare Advantage and Part D spaces. And when we look at the models in our portfolio, they've had a pretty broad impact across the country. In 2022, when we sort of took a look and assessed the impact of our models, there were more than 110,000 providers who were delivering care through our models in the CMMI traditional Medicare models. And there were more than 4.7 million people who were receiving care through those model tests. We also saw around 900,000 people with Medicaid who were receiving care through one of our models where we had a provider or a plan or an organization that was participating. In the first 10 years that the Innovation Center was in existence, we tested more than 50 models. And 6 of those models generated statistically significant savings to taxpayers and to the Medicare program. And 4 of those model tests met that statutory criteria for expansion. So those criteria, again, that were in the blue box that describe the statutory basis for expanding models in scope and duration. And in 2021, having been around for 10 plus years, we felt like there was an opportunity for us to revisit the CMMI strategy by looking back over the models that we had launched and run in that time and taking stock of the lessons that we had learned and then plotting a course for the next decade. And this slide lays out some of the lessons that we learned from this retrospective. For example, we saw that there was not enough of a focus in our model portfolio on reducing health disparities or including Medicaid. We also noted that where our models had lots of overlaps, that was challenging both for model participants and for those in the Innovation Center who were operating those models. Before going to the next slide, I'm going to spend a little bit of time on what is the second to the last bullet here, the success of the models and the way that we define that. One of the things that we noted as we did our retrospective look was that the way that we defined success, those statutory criteria, seemed to be too narrow. A model that manages to meet one of those criteria has an opportunity to go through what's called the certification process. And essentially what certification requires is that there is a 95% certainty of cost savings on a net basis. So that's a pretty narrow definition and not one that is very easy to meet. And it's particularly hard to do that in areas that have been historically underfunded. We also noted that the duration of our models, generally 5 to 7 years, was probably also creating challenges in terms of being able to detect any real impact. It's too short a period of time to really demonstrate a quick return on the investment that we make in these models. And then the last thing that I want to note is that as we looked at the investments that we were making in prevention, that we saw a similar dynamic. We knew that better screening, better diet, exercise, all of those things can prevent disease. But we also noted that the results of taking better care of yourself or your patients might not necessarily show up in healthcare costs for many years, and certainly not within the very short window of our model tests. In the history of CMMI, as I said, only 4 of our model tests have met that criteria for certification. But we think that there are actually impacts that the Innovation Center models have had that we haven't yet detected. And so we are currently working on developing a framework to help judge the impact of our work based on the notion of health system transformation. And that notion is that changing healthcare delivery in ways that improves quality and that reduce costs might result in improved outcomes that show up in the long run, and that those changes might also spill over into other parts of the health system that we're not currently detecting. So we're taking a look at all of the evaluations that we've run in the last decade. Every model test that we run is required to have an evaluation done each year. So the 50 plus models that we've run, they all have evaluations for each year that they were active in our portfolio. And we're looking back across all of those, and we're trying to identify common themes and common threads that resulted in positive changes that weren't necessarily part of what was considered in the certification process. In 2021, as part of that retrospective look, the Innovation Center launched a new strategy. And it was built on those lessons learned that you saw on the previous slide. And you can see in the center of this slide, the vision that we set out as part of that strategy is one of a health system that achieves equitable outcomes through high-quality, affordable, person-centered care. And to help drive towards that vision, we identified 5 strategic objectives to help us do that. And starting from the left, those objectives were to drive accountable care, to advance health equity, support innovation that's happening in our models, to address affordability, not just of the program, but also for beneficiaries, and then finally, making sure that we are partnering to achieve system transformation. And I'm going to talk about each of these strategic objectives in a little bit more detail over the next 2 slides. First, when we talk about driving accountable care, that means driving care that promotes delivery of whole person integrated care. For beneficiaries who are in traditional Medicare, who are not in a Medicare Advantage plan, we still want them to have integrated, coordinated care and patient navigation that will lead to better outcomes and improved quality for them. And we set a very, very ambitious goal for ourselves that by 2030, all of our Medicare beneficiaries and the vast majority of those beneficiaries who are in Medicaid would be aligned with a provider who will be responsible for their total cost of care and for quality. And that alignment could happen through an advanced primary care practice, it could happen through an ACO, but regardless of the entity or the organization, we want to make sure that there is meaningful accountability for the beneficiary's total cost of care and for outcomes that matter to patients like functional status and patient-reported outcomes. The next strategic objective is advancing health equity, and we are very, very focused on ensuring that health equity is woven into all parts of the work that we do at the Innovation Center. This is central to all of the work that we're doing moving forward, and we're committed to embedding it in all parts of our model life cycle. Part of what's involved here is making sure that we're reaching out to historically underserved communities and to individuals who are most in need of high-quality care. So we are thinking about ways to include more safety net providers in our models. We're looking at opportunities to ensure that the criteria and the application process itself, quite frankly, for our models don't somehow inadvertently exclude or disincentivize care for specific populations. We also want to make sure that we have a really good understanding of the beneficiaries who are being touched by our models. I said early on that the reach of the Innovation Center's models is broad. It is national in scope. But what we also want to make sure is that we understand whether the models are improving care for all beneficiaries or just for subpopulations. And then third, we want to focus on supporting innovation that enables the delivery of person-centered integrated care in our models. We know that in order to achieve the very bold vision that we've set out, the providers who are delivering care through our models need tools, they need data, they need resources, and they need flexibility. And that we want to make sure that all of that is consistent with the goals that the patients have for themselves. And this means that the Innovation Center has to provide a range of supports to providers in our models, including data that's actionable, practice-specific data, technology. We want to make sure that we're helping to facilitate the dissemination of best practices and peer-to-peer learning among model participants. And then where there are opportunities, we want to make sure that we're including payment flexibilities that providers can take advantage of. And as we're doing this, we're going to look at measuring our progress through understanding how patients who are receiving care rate their experience and the outcomes that they achieve. Fourth, we are focused on affordability. And as I said, we are required by statute to identify and address and realize programmatic savings through our models. We remain committed to that goal, but we also want to make sure that our models are also addressing affordability for people and for patients in our models. And work under this objective includes models that address low-value care and sources of waste that drive up patient costs and have proven challenging to address. And our progress in this area is going to be measured by how many patients continue to forego care due to costs. In addition, all of the Innovation Center models are going to consider affordability of high-value care by beneficiaries. And you can see some of what we're thinking about in the response that the Innovation Center delivered to the President's executive order on drug pricing. And then finally, we know that we need to partner to truly achieve health system transformation. And that's going to require aligning our priorities across CMS in tandem with commercial payers, with states and patients. And we know that the Innovation Center can't do this work alone, that meaningful commitment from providers and health plans and employers and states, among others, is going to be absolutely critical to achieving this vision for all people. And here we're going to look at measuring the progress that we make in aligning with other payers to drive greater equity and innovation. Pause for a minute. Oh, excuse me. So you've gotten a little bit of background on the Innovation Center, and you've heard about the strategy refresh that we've undertaken and the goals and the strategic objectives that we have adopted in order to drive progress on our goals. How does this all fit together? What does this mean going forward? This slide was actually part of the strategy update that we released in the fall. As we talked to providers and beneficiaries while we were conducting our strategy refresh, there was a lot of consensus around the need for the Innovation Center going forward to provide greater visibility into the work that we're doing. So what you see here laid out are both the models, the initiatives, and the stakeholder engagement that gives hopefully a greater understanding of what we're working on currently and what we are envisioning for the future. So I'm just going to walk through the slide a little bit to orient you. The middle boxes are the models. And these are specifically focused on our new models, but we also think that there is value in looking at continuously improving the models that are already in our portfolio. And in the later slides, I'm actually going to spend time talking about the models that we've updated and some of the newer models that we've released in the last couple of months. Across the bottom, what you see are the initiatives, including the cross-model issues. And those are things that we call enablers that help us to achieve our vision. And they include things like the work that we do in ensuring health equity data collection within our models, data access and transparency for researchers and providers. And then finally, across the top of the slide, we are describing the engagement that we have with stakeholders, which is so critical. And stakeholder feedback is a really important part of what we do, and we hope to continue to engage stakeholders with topic-focused listening sessions that we've been conducting as we've undertaken our strategy refresh. To be successful in our vision, we know that value-based care requires significant collaboration, it requires communication, and consistent information sharing. And it's no surprise that this is actually a key component of that fifth strategic objective, partnering to achieve system transformation. And we started sharing data with external researchers in 2022. Researchers to date have already been able to get claims data. What they haven't been able to know is who is participating in our models. And as a result, they weren't able to perform research on model outcomes or on the impacts that our models are having on the healthcare system. And so what we did to rectify that recently is establish a set of model files that are on CMS's Virtual Research Data Center. And we are doing quarterly updates to those files and adding data from new models as they are launched. To date, we have information from 14 of our models that's included as part of those files in the VRDC. Our goal for 2023 is to get that number up to 19. And we know that the data that is available there is already being used. We know that 14 researchers have already requested access to these data, and that they're using it to do research on things like the impact of our bundled payments for care improvements program on quality and cost of care. They're also looking at benchmark comparisons and performance analysis of our ACO or of our accountable care organizations. Going forward, as I said, we want to continue adding to the data that's there. We want to make sure that we're doing regular quarterly updates of those data. And then we want to see if there's an opportunity for us to also begin including some of the more unique data in our models, like the social determinants data from our accountable health communities model. Also in the data space, we know that there are opportunities for us to improve on the data that we deliver to participants who are in our models. We know that model participants use data to inform care coordination. They use it for population health management and for quality improvement efforts within their organizations. We share already claims data with our ACOs through a FHIR API, and we're doing this through the Beneficiary Claims Data Sharing API, which is part of the Data at the Point of Care initiative, which our colleagues in the Office of Enterprise Data and Analytics and CMS are running. We're also within our models offering interactive dashboards to our primary care providers and specialists. You'll see that we use this in our primary care first model. We're using these dashboards in our enhancing oncology care model and also in our new making care primary model. And these dashboards create a way for participants who are in our models to see the utilization and expenditure metrics for their attributed beneficiaries. So really trying to make sure that those providers have access to timely data that can help inform the care delivery in their practices. I'm going to spend just a little bit of time talking about our specialty care strategy, which is important because it's closely linked to our ability to execute on a number of the strategic goals that I discussed earlier. And that's because our goal requires engagement of the entire health system, and that includes specialty care providers whose expertise is critical to care that addresses the whole person. Over the last few decades, we know that Medicare beneficiaries have been faced with greater clinical and system complexity, and that most beneficiaries have one or more chronic conditions. And that means that the number of providers that they're seeing each year is increasing. And corresponding to that is the number of providers that primary care physicians have to coordinate with. And as we think about that coordination and interaction between primary and specialty care, there's an opportunity there to also impact healthcare spending, given that specialty care plays such a large role in overall spending. On this slide, I'm just going to note that the patient experience, even in our specialty care strategy, is really central and defines a lot of our thinking in this space. And you can see how all four elements of the strategy fit together across the patient's journey through the healthcare system, which is depicted in the middle of that slide. And I would encourage you, if you want to learn more about the specialty care strategy, to take a look at the web pages that we have set up dedicated to tracking progress on our implementation of our strategy refresh. So with that context of the overarching strategy and our specialty care strategy, I'm excited now to turn to our portfolio. And as I said, I'm going to talk about models that are in progress, I'm going to talk about models that have been updated and newly released models. And you can see here, this is actually the full list of all of the model tests that the Innovation Center has run in its 10-plus years. It includes models that are currently active. Those are in the black text. Models that have ended are grayed out slightly. And then the ones that are new, where we've announced them, but they aren't yet active, those are in the blue text. And I'm gonna focus on the models that are highlighted in green, but again, there is information about all of our model tests on the Innovation Center pages, and would encourage you to take a look at that if you're interested in getting additional information about any of these models that I'm talking about, or even ones that I'm not discussing. So I'm going to start with two of our currently active models, and then I'm going to share updates for those, and that's the BPCI-A Advanced Model and our ACO REACH model. And then I'm going to turn to our Enhancing Oncology Care model, which we launched in July, and then give an overview of our newest models, which are the Making Care Primary model, Guide and Improve Dementia Experience model, or our GUIDE model, and then finally our AHEAD model, the States Advancing All-Payer Health Equity Approaches and Development model. And I will be quizzing you on that at the end, so hopefully you're paying attention. Starting first with our bundled payment for care improvement model. As many of you are probably aware, BPCI-A was a new iteration of our continuing efforts in implementing a voluntary episode payment model. It was originally set up as a 5-year model, with the first cohort of participants beginning their work in October of 2018. And then we had a second cohort that started in January of 2020. And as of the beginning of this year, we had 280 participants in the model. And the model aims to support healthcare providers who invest in practice innovation and care redesign to better coordinate care and reduce expenditures while improving the quality of care for Medicare beneficiaries. And BPCI-A uses a bundled payment methodology, which involves combining payments for physician, hospital, and other healthcare payer services into a single bundled payment amount. And this amount is calculated based on what are the expected costs of all of the items and services furnished to a Benny during a particular episode of care. And just to give you a little bit more detail about the mechanics of the model, in BPCI-A Advanced, a clinical episode begins in one of two ways. It either starts with an inpatient admission to an acute hospital, or it starts with an outpatient procedure in a hospital outpatient department. And each clinical episode is the anchor stay plus 90 days from the day of discharge, or it is the anchor procedure plus 90 days beginning the day of the outpatient procedure was completed. And once a clinical episode begins, it is then attributed to a participating physician group practice or to an acute hospital. And the clinical episodes are constructed to include, again, all of the services that overlap with the clinical episode window, and there are just a few exceptions to that. And then at the end of each performance period in the model, participants' performance is assessed against specific quality metrics and the actual expenditures that they have for each of the clinical episodes, which are compared against a final target price for the episode. So that was a lot, and I'm sure that maybe was not super clear, but lots more detail available on this model on our website if you're interested in really understanding in more detail the mechanics of how that model operates. This slide highlights the recent changes that we made to BPCI-A. The model was set to end, and we have extended it for 2 additional years. And we made that decision in October of 2022, and there were really 2 reasons that we extended the model. The first was because of the contribution that that model makes to our larger specialty care strategy. Specifically, it helps us to maintain momentum on acute episode payment models. And then the second reason for the extension was to continue driving essential care delivery changes and transforming how patients transition between hospitals and post-acute care. Earlier this year, we published a request for applications, or an RFA, for BPCIA, and that was to recruit a brand new cohort of participants. So this is going to be cohort 3. And the current participants in the model are going to be permitted to continue to remain in the model for the 2-year extension. They will have until, I believe, December of this year to make a decision about whether they are going to participate in the model during the extension period. Apologies. And so maybe the last thing that I'll note on here is that at the bottom of the slide, you'll see that we describe some of the pricing and methodology changes that were also made in the model. Again, this was part of the 2-year extension. These kick in with the start of that period. And again, if you are interested in additional details about the changes that were made to the model, we capture all of that on the Innovation Center webpage. The second of our existing models that we've updated that I want to talk about today is our ACO REACH model. And it is currently active and is scheduled to end December 31st of 2026. And in performance year 2023, the model had 132 ACOs participating, which translates to over 130,000 participating providers and an estimated 2.1 million beneficiaries who are aligned with those providers. And this particular model enables the Innovation Center to test an ACO model that can inform what we are looking to do in our Medicare Shared Savings Program, as well as other ACO models that we are planning in future. It encourages health providers, including primary and specialty care providers, hospitals, and others, to come together to form coordinated care management entities called ACOs. And the ACOs take on accountability for cost and quality of care delivered to a discrete pool of aligned beneficiaries. And the model itself includes 3 different types of ACOs that reflect sort of levels of experience and the type of patients that are cared for. So we have a standard ACO, high needs populations ACOs, and new entrant ACOs. One of the innovative elements in ACO REACH that I want to spend a little bit of time on, and that you're going to hear about in a couple of our other models, is the use of a health equity strategy. Health equity, advancing health equity was the second of our strategic objectives. And again, we made a commitment to ensure that we are incorporating that in all aspects of our models. And so it is not surprising that this is showing up in most of our newer model tests. And in ACO REACH in particular, the model requires participants to both develop and implement a robust health equity plan that needs to be able to identify underserved communities and implement initiatives within the model to measurably reduce health disparities within their beneficiary populations. In addition, the model test is also offers an innovative payment approach to better support care delivery and care coordination for patients in underserved communities. And this element of the payment structure is called the Health Equity Benchmark Adjustment. And what it does is increase the ACO benchmarks, and by extension, increases the resources that are available to deliver care and potential savings based on the number of underserved beneficiaries who are aligned to providers. So taken together, these elements of the model are meant to improve the quality of care and the health outcomes for all traditional Medicare beneficiaries. We announced a coordinated set of policy updates in the ACO REACH model for performance year 2024 in response to what we heard from stakeholders. And so starting from left, these updates are meant to further advance health equity so that the health equity benchmark adjustment was improved as part of this update. And we're hoping that these adjustments will help to better identify underserved beneficiaries, that it will increase the impact of the adjustment by providing funding to model participants for an even larger percentage of their underserved beneficiaries. So really increasing the impact of the health equity benchmark in hopes that providers who are taking advantage of that will be able to provide improved care to an even broader group of patients. We've also expanded the nurse practitioner and physician's assistant benefit enhancement to include certification of pulmonary rehabilitation. And then some of the changes here are also meant to protect against inappropriate risk score growth and maintain consistency across CMS programs and models. In particular, we've updated the risk adjustment model used for the standard ACOs in this model and the new entrant ACOs so that it matches the approach that's used in Medicare Advantage. We've also implemented changes that limit the impact of risk adjustment coding intensity factor on low coding ACOs. And then the last set of changes that you see up here is meant to increase for providers the predictability of model participation. So we've reduced the escalation of beneficiary minimums, so that the minimum number of bennies that need to be aligned. We've reduced that for payment year 2025 and 2026 for high needs ACOs and new entrant ACOs, so that we're setting a level of growth that is consistent, predictable, and more attainable for these particular types of ACOs. And in addition, recognizing that there are sometimes temporary fluctuations in beneficiary alignment that ACOs might not be able to predict very well, CMS is also going to provide a 10% alignment buffer beginning in payment year 24. And then finally, we expanded the eligibility criteria for beneficiaries who can be aligned with those high needs ACOs. And beginning in 2024, the eligibility criteria for beneficiaries is going to expand to include bennies who have at least 90 Medicare covered days of home health service utilization, or who have at least 45 Medicare covered days in a SNF within the previous 12 months. So again, expanding the pool of beneficiaries who are eligible to be aligned with these ACOs who are participating in the model. And I'll say again, that was a very high-level overview. If you are interested in more details, if you have questions, the website that lays out all of these updates will give you far more detail than I'm able to provide today. So please stop by and take a look. And now I'm going to move on to one of our newest models that just became active a few months ago. This is our Enhancing Oncology Model, or EOM. And it is a 5-year voluntary episode-based payment model that kicked off in July of this year, and it runs through 2028. There are currently 44 physician practices that are participating in the model. And across those participants, there are over 500 sites of care that represent 34 states and nearly 3,000 practitioners. EOM also partners with 3 commercial payers. And the model itself focuses on innovative payment strategies that promote high-quality, equitable, person-centered care for Medicare beneficiaries with certain types of cancer diagnoses who are undergoing chemotherapy treatment. And it builds on lessons from a previous CMMI model, our oncology care model, which was a 6-year model test that ended in July of 2022. Under EOM, model participants are incentivized to consider, again, whole patient care and to engage with patients proactively, both during and between their chemotherapy appointments. And to do this, participants in the model are expected to implement what we call participant redesign activities. And that includes things like giving access to 24/7 care, providing patient navigation services, offering care planning, using evidence-based guidelines in treatment, and using certified EHR technology. And as part of using data for quality improvement, participants are again going to be submitting health equity data plans that are going to detail for us their evidence-based strategies to mitigate health disparities identified within their beneficiary populations. And again, that's a theme that you're going to continue to hear and see, this requirement for model participants to develop and to implement health equity plans that help describe for us, for the Innovation Center, their strategies for both identifying and reducing health disparities that they've identified in their patients. EOM uses a two-part payment structure. The first part involves practices receiving fee-for-service reimbursement with an option to bill a $70 monthly enhanced oncology services payment, or a MEOS payment. And that MEOS payment is meant to to give providers the ability to provide enhanced services to their patients during the six-month episodes. EOM also includes an additional MEOS payment of $30 for dually eligible beneficiaries, and that is an acknowledgement of the greater resources that may be needed to care for complex and underserved communities. And then the second part of the payments in EOM has EOM participants potentially earning a performance-based payment. If the costs that providers have are lower than their target, or and that allows them to earn the performance-based payment, or if their costs exceed the target, they may owe CMS a performance-based recoupment. And the model adjusts these amounts depending on the participant's quality performance. Okay, and you're gonna get sick of me saying this, but again, that's a very high-level overview of the model, but there is a lot more information, more detailed information about this model on our website, and about the changes as well. All right, and now we are going to talk about a couple of models that we recently announced. They are not active yet, so these are models where we have told the world we're going to be running the test, and we are either in the process of recruiting participants or we are just gearing up to do that. So these are really, really new models, and I'm starting with our Making Care Primary model, or MCP, which we announced in June. And this model is scheduled to launch in July of 2024. And it is actually a 10.5-year model test, so much longer than the usual 5 to 7 years. And it is focused on improving care management and care coordination, and equipping primary care physicians with tools to form partnerships with healthcare specialists and leverage community-based connections to address patients' needs, as well as their health-related social needs, such as housing and nutrition. And the model is built on the foundation of the more than 10 years of testing primary care models. I think I said earlier that pretty much every year since we've been in existence, we've had a primary care model or two running, and that has not changed. That continues to be true. But more specifically, the Making Care Primary model builds on our experience in our CPC model, CPC Plus, Primary Care First model, to make advanced primary care available and more sustainable for smaller independent practices that serve a more diverse set of patients, to make sure they are improving quality, health equity, and overall patient care. And MCP's approach to care delivery is really comprised of 3 domains. First is care management, and that includes self-management supports for the patients themselves, care integration between primary care clinicians and specialists, and then finally, community connections to address, again, health-related social needs. And this model is going to attempt to strengthen coordination between primary care clinicians, specialists, and strengthen the connection with social service providers as well. This slide lays out some of the key elements of the MCP model, and I'm just gonna very quickly run through these. First, the model provides an on-ramp for primary care organizations that are new to value-based care. So really trying to draw in those clinicians who are new, haven't previously participated in a value-based care model. It includes an explicit focus on smaller independent practices and on safety net organizations like FQHCs, many of whom are serving rural communities. And we provide in this model an upfront infrastructure payment to eligible providers who, again, are new to value-based care, and we plan to adjust payments to better support providers caring for complex populations. Next, MCP advances health equity by adjusting some of the payments for beneficiaries' clinical indications and social risk. It also requires participants to develop, again, a strategic health equity plan for how they will identify and reduce health disparities. And then finally, requires participants to implement health-related social needs screenings and referrals. And then third, MCP offers a longer model test, 10.5 years, much longer than our usual 5 to 7. And this is because we think it takes time to achieve transformation, particularly in parts of the health system that have been historically under-resourced. And for this reason, MCP is set to run for 10 years, and it includes a 6-month implementation period. And within the model, there are actually 3 progressive tracks that are designed to recognize the varying levels of experience that participants are likely to have with value-based care. Again, as I mentioned, we are trying to draw in participants who maybe are participating in a value-based care model for the first time. We also want to make sure that we are drawing in providers from under-resourced areas and those with existing primary care and alternative payment model experience as well. MCP aims to give these organizations flexibility, allowing them to choose the track and to receive payments that reflect their unique needs and the patients that they care for. MCP incentivizes integration, again, of primary and specialty care to better serve those who have chronic and serious health conditions, and this includes support for e-consults between primary and specialty care providers. It includes co-management for those with chronic conditions that require collaboration across a care team. And then finally, the model has a strong emphasis on partnership with states. So previous models have had sort of a broad geographic scope. MCP is focused on a specific number of states with greater depth. There are currently 8 states that are participating in the model. They are Colorado, North Carolina, New Jersey, New Mexico, New York, Minnesota, Massachusetts, and Washington. And we are actively working with the state Medicaid agencies in these states to achieve meaningful multi-payer alignment. And all of these states have agreed to align with CMS across a number of quality measurement areas in the area of data sharing and learning supports and moving away from fee-for-service payment. The application portal for MCP is currently open, and it is scheduled to close on Thursday, November 30th. So this is one where we are actively recruiting participants right now, although the window is quickly approaching. And we encourage anyone who is interested in applying to begin an application. Our team is able to provide assistance, but it is a little bit easier to do that once an application has been started. All right, and the next model that I'm going to talk about is our Guiding and Improved Dementia Experience, or our GUIDE model. This is an 8-year national model which is going to be offered in all states, U.S. territories, and the District of Columbia. And it was just announced in July and is scheduled to launch in July of 2024. And the GUIDE model aims to address the existing gaps in our nation's current dementia care landscape, and to do so by defining a standard dementia care delivery program, providing an alternative payment methodology, addressing unpaid caregiver needs, and then covering respite services. beneficiaries who are getting care through the GUIDE model are going to receive care from an interdisciplinary team that's going to identify the Benny's primary care provider and specialists. They're going to outline the care coordination services that are needed to manage the beneficiary's dementia and co-occurring conditions. And then through virtual or in-person services, GUIDE participants are going to be required to provide a caregiver support program. So again, a program that is going to be based on the needs of unpaid caregivers, and to determine specifically what they're providing, participants will need to do an assessment, and they're going to have to be responsive to ongoing needs of caregivers. And then finally, GUIDE is also going to provide payment for a defined amount of respite care for certain eligible beneficiaries and their caregivers in the models, which is going to hopefully allow these unpaid caregivers to take a temporary break from providing care to these beneficiaries and attend to their own health and well-being. GUIDE is designed to attract a range of Medicare Part B enrolled providers and practitioners with expertise and capabilities to establish that dementia care program and to provide the ongoing longitudinal care and support that's needed by people with dementia. And ultimately, we think this model is going to test whether a comprehensive package of collaborative care, caregiver support, and education, coupled with respite services, is going to improve the quality of life for beneficiaries with dementia and their caregivers, and whether it can delay long-term nursing home facility placement and enable more beneficiaries to remain at home through end of life. We are currently accepting letters of interest for the GUIDE model. And if you don't know what that is, it is simply a non-committal commitment to participate in the model. So entities that are interested, we ask them to simply let us know of their interest so that we can gauge sort of the interest in the model and gauge the size of the cohorts that are likely to participate in the model. And we are currently accepting those letters of interest and are expecting to then subsequently release our requests for applications for the model later on this year. So we're going to be following up in very short order with requests to participate in the model. All right, and the last model that I'm going to talk about today is one that we announced most recently. This was announced in September, and it is our states advancing all-payer health equity approaches and development, or our AHEAD model. And it's a multi-state model that aims to address unsustainable healthcare cost growth, poor population health and health outcomes, and unacceptable disparities in health outcomes. And the AHEAD model proposes a significant restructuring of the healthcare system spending across all payers in a particular state or region. The AHEAD model, we think, is going to be our most innovative model to date. It's going to run for 11 years, so topping the 10 and a half, we've moved on to 11. And that includes a pre-implementation or ramp-up period for model participants. And the performance period for all participants is going to end in 2034. And we think that having an 11-year model in this instance is necessary in order to achieve the population health improvements that we are looking to implement through the model. And we recognize that the model is very ambitious in its design. It combines elements and lessons from multiple previous CMS models, including our Vermont all-payer model, our Maryland total cost of care model, and our Pennsylvania rural health model. So pulling from a number of our existing state models to develop this one. And it also tests a flexible framework that includes statewide accountability targets for all payer and for Medicare fee-for-service growth, primary care investment, equity, and population health outcomes. And it's going to include up to $12 million in cooperative agreement funding. So that's the funding that we will be providing to the states that are included in the model, and that funding is meant to support infrastructure development, alternative payment methodology development, population health activities, and model implementation. And we hope that the model is designed to be flexible enough to meet states where they are. We recognize that not all states are in the same place. So we have tried to build in flexibility to ensure that we're meeting states where they are and that we're able to support their ongoing transformation efforts. The Notice of Funding Opportunity, that is the equivalent of the RFA, but for a model where we're giving cooperative agreements. That request is going to be posted in early December of this year. And then there's going to be a second application period in spring of 2024. So there'll be two opportunities to apply and to sort of throw your hat in the ring. And states are going to need to be able to select how much ramp-up time they want, so how long that, that pre-implementation period is. And CMS is going to select up to 8 states. So a total of 8 states will be participating in the model. Applicants can be either the state Medicaid agencies or other state agencies or entities with rate setting, or budget authority in the state. And once selected, the states are going to be responsible then for recruiting the hospitals and recruiting the primary care practices that are going to be selected to participate in the model. And then finally, the states are also going to, in ahead, be responsible for achieving all of the model's goals. So our partnership is most directly with the states, but the states will then be partnering with hospitals and primary care practices in order to perform in the model. And we are excited to be able to announce this model. It was one that was a long time coming, and we were really happy to be able to announce it this September and are looking forward to beginning to operate the model. And so that, I think that's the last model update. And this slide just gives you information for the Innovation Center pages. If you're interested in seeing more information on our strategic refresh and our progress there, if you want to follow the work that the center is doing regularly, you can sign up to receive regular email announcements and information about model updates, release of white papers, roundtables that we're convening. And then, of course, follow us on social media if you're interested and so inclined. That is it. Thank you so much for your time. It's been a pleasure, and I hope that we still have time. I'm sorry, I was supposed to be watching you, and I wasn't. I apologize. If you have questions, though, I'm happy to, if you want to reach out to me, I can provide you with my information, and I will get back to you or have someone on our teams get back to you. But thank you again. It's been a pleasure and really happy to be able to join you today.